Now coming towards the core of today's workshop, that is a deep brain stimulation, I would like to invite Dr. Danish Bhatti. I can say about him that when it comes to molding the young brain, there is no one better than Dr. Danish Bhatti, as everybody who has joined the MDSP WhatsApp group, they know him very well as his professional expertise in the field of the movement disorders. He's working as an assistant professor in the Department of Neurological Sciences at the University of the Nebraska Medical Center, USA, and his specialties and the interests include movement disorders, Parkinson disease, and the DBS. He is currently the co-director for multidisciplinary Parkinson disease clinic, director for international neurology and observership programs, and curriculum director for movement disorders fellowship. Dr. Danish Bhatti will discuss two topics, that is the patient selection for the DBS and the advantages and the disadvantages of the different available targets for the DBS. So please welcome Dr. Danish Bhatti for the next talk.
So we're going to switch gears a little bit. For the consultants here, I'm handing out some of education material on DBS. So hopefully they will be useful for you to review yourself and review with your patient if this question ever comes up. One of them is for essential tremor and one of them is for deep brain stimulation. For Parkinson's disease, both of them have patient video. You can probably copy it on a computer and burn it on a disk for them, and photocopy the text material if you want to hand it out for them. Hopefully you will find it useful. So we're going to switch gears a little bit, and we're going to take that complex information about Parkinson's disease and now ask a very simple question. And that simple question is that which of these patients I can take and offer them a deep brain stimulation surgery. Most of this information is also relevant for the lesional surgery, but has additional complication that I will not be reviewing. So the focused question is that what are the right patients and what is the right target for deep brain stimulation in Parkinson's disease. Parkinson's disease only, I will not be talking about other indications. Alright, so let's look at this question. Here's my team for movement disorders in University of Nebraska. We have 4 faculty movement disorders, and we have 1 expert on dementia, 3 case managers, and other staff. We do about 100 DBS surgeries a year for all indications, including tremor, dystonia, and Parkinson's. Here's my disclosures. I am on the speaking panel for Teva and Acadia Pharmaceuticals and Allergan Pakistan, and I get research funding from AbbVie for Parkinson's disease research. I would like to dedicate this lecture to the memory of my father, who passed away this year, and he wanted me to do a lot more education. So DBS is not something new. We're talking about it, but it's not an investigational treatment. There are over 140,000 patients who have DBS as a treatment. So it's a very well validated and a commonly used treatment. So what are we going to reach or obtain from this talk today? I want you guys to be able to describe the essential features of Parkinson's patient that will get better with DBS and the ones that will not get better with DBS. So you can select your patient and educate them. I want you to explain the recommended process of patient evaluation. So some questions you can answer right away when you see the patient in your clinic. The other questions you need to do a process to evaluate and answer those questions. So just one clinic visit is typically not the recommended way of selecting the patient. There is a whole process that I will very briefly review that you can use to answer all those questions on what is the right patient. And then we will talk a little bit about what are the difference in different targets in the brain. So the wire that goes into the brain, which area should it go to for which patient? And we will look briefly at what is known about that. Very good. So I'm going to be sharing my experience of movement disorder clinic at Shifa Hospital, Islamabad. We're already doing DBS evaluation for candidacy for patients over there to see who will be a good candidate, who is not, at least starting the process going. So I'll walk you a case that we had over there. So it's a case of Raja, and it's not a real name, who is presenting to Shifa Hospital, and as you can see, he's a relatively young person. So he's a 22-year-old male. He has no family history of Parkinson. He had an onset of right hand poor dexterity in 2012 with changes in handwriting at the age of 18, which was soon followed by right hand resting tremor in few months. This was followed by right foot dystonia, right leg dragging. He later reported onset of tremors in the left arm and then right leg tremor by 2015 and freezing of gait in early 2015. So a very typical progression for a young onset PD This will be a very fast progression for an old onset PD, but this is very typical and acceptable progression for a new young onset PD. He admits to some balance problem, but no falls, and denies any significant dysautonomia. So on examination, there is a typical resting tremor, there is true rigidity, true bradykinesia, and freezing present, baseline unified Parkinson disease rating scale, UPDRS 3 score was 56 and fully off state, and he's not taking any Cinemet. Why? He had tried it twice before, and he gets significant medication-induced dyskinesias for 1 to 2 hours and mild, insignificant wearing off between doses. He has also noted medication-induced anxiety and wearing off of mood changes and nervousness. MRI of the brain images show no atypical finding. Blood work including movement disorder panel 1 was reviewed and was normal. So this is a case of a patient. Imagine you have it in your clinic, 4 years of disease, not able to take Cinemet, is having dyskinesia, has a typical progression, somewhat rapid but normal for young onset PD, and now he is there in front of you and is asking you this question: should I get DBS surgery? What would you tell him about the benefit that he should get from the DBS surgery, and what target would you select for the lead? So that's the question that you ask yourself anytime you see a Parkinson patient, and we'll review some data to see if we can answer these questions. To answer these questions, we need to know, does it really work? Will it work for him? What will get better? How much will it get better? What target should we select? And are there any risks? He's 22. He's 22. He has his whole life in front of him. Very good. So remember 3 guiding principles about DBS. I have spent years of training to boil it down to this simple answer for you. 3 guiding principles. Remember that. Principle number 1, DBS only works for patients with idiopathic Parkinson's disease and does not work for any other Parkinsonism. So you have to have your diagnosis right. Don't get fooled by MSA, don't get fooled by vascular Parkinsonism, for medication-induced Parkinsonism, by PSPs and CBGDs, which are more easy to distinguish, but the real kickers are the MSAs. They fool you like anything, and vascular Parkinsonism, and medication-induced Parkinsonism if you did not took a right history. So it's very easy to be fooled. So remember, idiopathic Parkinson's disease only. Number 2, all the symptoms that get better with Cinemet or levodopa will get better with DBS, and the ones that do not get better with levodopa will not get better with DBS. Okay? And number 3, both STN and GPI, the 2 common use targets, are equally good for motor symptoms. So yes, target selection may be important, but maybe in most patients it will not be important. There are differences. There are differences in some areas, and I will highlight some of those, but both of them work for motor symptoms of Parkinson's disease. Very good. So now we can all go home. We know which patients to go and get DBS done, right? I wish it was that simple. So let me go into some of the difficulties. So what is DBS? You know, I'm the first one starting, so I have to introduce this, but speakers after me will telling you a lot more about it. So just a general introduction. DBS or deep brain stimulation is a technology where we put wires in certain targets of the brain, hook it up with a pacemaker-like battery. The battery is completely programmable. You can change the voltage of the current, you can change the frequency of the current, you can change the width of the pulse of each frequency of the current. So you have 3 different parameters. Each parameters you have couple of dozens or more options available. So which means that if you add all these combinations together, you have over 6,000 possible combinations. 6,566 to be close to be accurate. Combination possible. That's why you have to have algorithms. You have to have an idea of what's going to affect what does voltage do, before you can select the right technology, right setting. And that's where programming lecture will come in today. DBS has been proven to be beneficial for a number of conditions. We're focusing on Parkinson's disease today, but it's well established for essential tremor and dystonia, and is being currently studied for 21 other indications. And 2 of them are pretty close to be coming out. Refractory epilepsy and refractory depression is going to be out probably within a year or 2. So you will see more of DBS, not less of it. This is something you cannot avoid. You need to know about this technology. Deep brain stimulation, the wire has to be very carefully placed. If you look at the tip of the lead, there are 4 contacts, and you can choose which contacts you want to use and what combination. The new leads that are coming out will have as many as 100 contacts. So you will have a lot of flexibility on exactly which part of the brain and which angle of the brain to stimulate. Here's a patient. So has advanced Parkinson's disease, has had DBS done before. Patient is camptocormic, severe posture, PASA syndrome. You see the tremor in almost all 4 limbs. You see difficulty with speaking. Patient cannot speak, cannot communicate, cannot get up, can literally do nothing. And then we will turn on the DBS. And as the DBS turn on, all the tremors stop. Patient's posture improve. Patient sitting more upright, is able to communicate. You can actually see the markings of the scar of the DBS on the top of her head and skull, and she's able to be more effective. She's still not perfect. This is not a cure, but she's far more, socially able to interact and have better quality of life. So who should be considered for DBS? As I've said before, remember, it's only for idiopathic Parkinson's disease and not for any of the other Parkinsonism. Don't forget step 2 and step 3 in the UK Brain Bank criteria. As Dr. Athar has highlighted, remember, pay attention to exclusion criteria, pay attention to positive prospective criteria. So here's a list of some of the things that fool me often. So on the negative sign, don't forget to check the cerebellar sign, severe autonomic involvement, dementia, upper motor neuron sign like Babinski. Now many times you will skip that, it's Parkinson, why do we need to check Babinski? That can change your whole diagnosis. And MRI abnormalities, and you need to see that it was unilateral onset, it had a persistent asymmetry, it had levodopa-induced dyskinesia. So those things can help you. When should we consider DBS? Okay, does all Parkinson's patients get it? How soon? DBS only works for idiopathic Parkinson's disease, but at a certain stage. We think of it as a therapeutic window. If you give little too much, you will cause a medication-induced dyskinesia. If you don't give enough, they don't have improvement in their symptom. But that range of what's too little and too much is very broad in the beginning. So almost any medication dose that you start will be fine. Some people will start a quarter of a pill 3 times a day and their patients will be happy. Some people will start a full tablet 3 times a day and their patients will be happy. Because they have such a huge therapeutic window, they're doing fine. But with passage of time, the therapeutic window starts to narrow down. You start first wearing off. Patient says 3 times a day is not enough. An hour or 2 before my next dose, I'm off. My tremors are back. So they start taking it more frequently or a higher dose. But then they develop medication-induced dyskinesia. So they're off, they get better, they go into a dyskinetic state, they come back down. So these motor fluctuations throughout the day become worse and worse with time. These are the patients that we can improve with DBS. So DBS is beneficial when the off periods are at least 3 hours a day, when you have on time with troubling dyskinesias, and when there are sudden or unpredictable off times, and when you're not pleased with your ability to control the movement despite using many medication. So classically, or typically it's called medication refractory Parkinson or therapeutic failure. So you have to have off time, dyskinesias which are troubling and that are just not controllable with medications anymore. So what does DBS do? DBS will smoothen that fluctuation that was happening with medication and will provide a more narrow within the window time during the day. So one way of looking at this is that you ask the patient how much on time without dyskinesia does he have. So on time without dyskinesia. So not off time and not on time with dyskinesia. And you can increase that amount of on time without dyskinesia by about 6.1 hours or up to 6.7 hours in some study. So you are prolonging that on time without dyskinesia. So he's on, he's not wearing off, but he's on without having any dyskinesias. So that's the best way of looking at what you are achieving. So in this particular study it was 5.1 hours, but latest data suggests as many as 6.7 hours is useful. And it is beneficial for years and years later. The longest follow-up that has been published so far is about 15 years. And up to 15 years has no loss of efficacy. The disease does progress with time, but it always works. Whenever you turn it off, they will be worse off, and you turn it back on and they will be better. So what are the patient goals? What does patient should ask for or think of or should be told that this is what we want to achieve with this therapy? We want to improve that on time of medication, so they are more on during the day without dyskinesia, improve the dyskinesia and improve tremor control. What will get better with DBS? So remember principle number 2, everything that gets better with carbidopa levodopa will get better with the DBS, and anything that does not get better with levodopa will not get better with DBS. And what are those things? So we have a whole constellation of symptoms, and here's a proof of the evidence again that we said that it works. So this study in 2006 by Deutschel from Germany had 78 patients on best medical therapy, BMT, and 78 patients on DBS, and what they found was that the rating of the severity of motor symptoms, the UPDRS, improved by 20 points. So from a 48, it went down to 28 points with the DBS therapy. They also found that quality of life was significantly better. These results are immediately after surgery, a 10-point improvement on a quality scale, PDQ 39. Other study by Weber et al. Published in JAMA in 2009, 121 on best medical therapy, one on DBS and 124 in best medical therapy. And again they found that the on time went up by 4.6 hours during the day. And the more than 5 points improvement on UPDRS, which is a significant improvement for patient clinically, less than 5 points is not clinically significant, was seen in more than 70% of patients. So 2/3 of the patient has a clear, significant, detectable benefit on their motor symptoms. Alright, so remember, all that get better with levodopa will get better. So what about the non-motor symptom? There are some non-motor symptoms that occasionally respond to levodopa, but we all have realized that many non-motor symptoms do not respond to levodopa. So drooling, for example, very common problem, does not respond to cinnabar or levodopa or dopamine therapy. You have to use anticholinergic therapy, or better yet, use Botox for drooling, most effective for it. Many other things, mood, depression, anxiety, bladder problems, incontinence, sleep issues, they will not get better with DBS. They are not what are levodopa responsive. What else will not get better? Postural instability. So falling patient, a patient who is falling regularly despite taking optimal levodopa therapy will not have any benefit from DBS. That's the most common complaint in a patient who was not counseled very well. They come back and they say, I still cannot walk. Well, who told you you're going to walk after DBS? It does not improve the postural instability because levodopa doesn't do that either on most patients. Cognitive impairment will not get better. It can actually get worse after DBS. So one of the important things is to screen for any cognitive impairment before sending patient for DBS, because it can stay the same or get worse after DBS. And hypophonia, speech problem, dysarthria, dysphagia will not get better with DBS, and actually in some patients it can get worse. Some stimulation parameters can cause dysarthria worsening. So you have to select the right patient and counsel them right. So here's a patient who will not be a candidate for DBS. Patient is severely akinetic rigid, he has not much of a tremor, and he has significant freezing, he freezes almost every step, and he is having a postural instability with an abnormal pull test, and that will not get better with DBS. So here's one of my partners, Dr. Merman, who's head of our behavioral neurology clinic.
Should I push in a little bit? I'm going to pull you backwards. If you can, try to catch yourself, okay? But I won't let you fall.
So he just falls backward. This patient will not get better with DBS. At least this complaint will not get better with DBS, so he may not be happy. So what are the risks of DBS therapy? Okay, we have found a patient who is very levodopa responsive and can do very well. He's not having any of the symptoms that will not respond, like he doesn't have any postural instability, cognitive impairment. Should he go for DBS? What can go wrong? Well, it is a brain surgery. You have to remember that. You're making a hole, you're poking a wire into it almost blindly. You have something to guide you, but you're not looking at any of the blood vessels inside the brain. You're just pushing it in. So what can go wrong? Early on, there was a lot more risk. So this data is very old, more than 10-year-old data. We have improved a lot. But just to show you, when you're starting a DBS program, let's say, in a place, this could be essentially the actual numbers. And with time, as we learn and become better and better at it, these numbers can and have gone down in many centers. In our center, the results are much better. So infection around the implanted device, we see about 2 to 4 infections a year out of those 100 patients that we do, which have that infection of the wire. We have to pull the wire out and just cancel the whole surgery. You can have some weakness or loss of strength or energy. You can have bleeding in the brain. We see about 1 bleeding a year or every other year. So out of 100 to 200 patients, we have 1 patient with some bleeding. Typically it's minor, but it can be bad enough to cause death or a major stroke. And you can have paralysis on the other side. You can have seizures. 2 to 4% patients can have seizures from it. So there are risks of DBS therapy. And then more importantly to remember is that there is, so here's the data from the study of the 255 patient. 93% were fine and 7% had some complication, including seizures and stroke. But more importantly, remember, there are cognitive side effects from the therapy, and if you do not carefully screen for cognitive problem, the risk of cognitive side effect is much higher, much higher. Mild cognitive impairment or MCI patient will do really bad post-operatively, and in the long run, with many of these problems, they can develop hypomania, they can have a rapid progression of worsening of their dementia, they can have severe depression up to 17%, and they can have a severe apathy where they just don't want to do anything. So you have to carefully screen for neuropsychiatric issues before doing the DBS. So when not to consider DBS, here's a summary of everything again. Do not consider DBS in any suspicion of atypical Parkinsonism, any lack of sustained levodopa response, because things that don't get better with levodopa will not get better with DBS, and any concern for dementia, typically moderate to severe dementia, but in our center, we even mild dementia, and even with MCI, mild cognitive impairment, we have to be very, very sure of the benefit before we will take the chance of doing the surgery because of the post-op complication. You know, patients are more sensitive to loss of things than gain of things. So if they don't gain something, they may not be that upset, but if they lose something, meaning that they become cognitive abnormal, or they have a negative bad effect, they're very sensitive to it. They will be very unhappy about this situation. So how should we evaluate for DBS? So what's one of the process? This is a process that is followed by many big centers in US. It's called the CAPSET protocol, and I'm going to show you how we do it. So of course, you have to have a program to do this evaluation. So you need a movement disorder evaluation to think that you have a reasonable idiopathic Parkinson's disease diagnosis. Has to be done by an expert who is comfortable with making that kind of a judgment, because there is no scan or blood test that will do that for you. You have to have a patient selection process. You have to have a team who is familiar with DBS to meet and decide on the selection of patient. You need intraoperative brain mapping, post-op programming, battery checks, and battery replacement process. So you start with a clinic evaluation. You look for problems that will not respond and problems that will respond, and confirmation of diagnosis. Then you move on to what is called on-off evaluation. On-off evaluation is the levodopa response challenge, which is done in our center. It's done in the hospital. Patient come in the afternoon, get admitted to the hospital. We stop all of the medications that are for Parkinson. He becomes completely off by next morning after 14-16 hours of off time, and we do a full evaluation of what is his Parkinson's disease in a full off state. And then we do a big challenge dose of levodopa to give him the best chance of improving everything that levodopa can improve, and much higher than typical dose, usually 150% of the typical morning dose. And then we'll look at for what things are getting better. So let's say he comes in, he's having some problems with walking, and we think it's mainly freezing. The question is it a levodopa responsive freezing or not? So you do a gait speed in the off state, then you do a gait speed in the on state. Typical normal gait speed for 6 meter timed walk is about 8.5 seconds. So if your patient had a minute to walk 6 meters back and forth and sit down before levodopa challenge, and then with the levodopa challenge it came down to 10 seconds, 11 seconds, that means he is having a levodopa responsive gait problem, levodopa responsive freezing. That is something you can offer, that this may get better with the DBS. But if it was 57 seconds before, 51 seconds afterward, there has not been any significant improvement, there was waste of time. So you need that challenge test to know exactly in a controlled environment what is getting better and what is not getting better. And then we are looking for more than a 50% improvement in rating scale. We use Unified Parkinson Disease Rating Scale. Maybe 30% is acceptable based on the goals. If it was he had a severe tremor and he had some gait problem, and you do the score, and the score is only 30% better, but the tremor separately is nearly 100% better, and other gait is not better at all, then you may still consider DBS. But on the whole, general principle to be on the safe side is that a 50% improvement on the rating scale before and after challenge dose is required for selecting for, of the 3 large trials, 2 of the trials had this criteria for their DBS response. Neuropsychological testing, very, very important. We have 3 neuropsychologists that do specific testing for us. We do a full neuropsychological battery, which is about 3.5 hour long test. At minimum in the studies, they used a dementia rating scale, which is a 144 points rating scale, which rate many different subdomains of psychological issue. But we also screen for depression, we also screen for hallucination and manic issues, apathy, many other things that can get worse with DBS. So you have to screen for those and have some level of confidence before sending for DBS. So at minimum you need 135 points on the dementia rating scale or more if you can do just one thing. MMSE and MoCA will not work. MMSE and MoCA will not work, not sensitive enough. You need at least a DRS testing, which may be available online, and you need 135 points to be sure. Now we have sent patients with up to 125 or 121 points for surgery, but again, you have to be very confident of their social support, their exact goals, and then you have to be praying afterwards that nothing goes wrong. Brain imaging can help, but it's a long debate for another day. It's important to look for microbleed. Many of these patients can have concomitant angiopathy of Alzheimer's, so they're 70 years old. If they are already having microbleeds in the brain, the risk of bleeding post-operatively is considered very high. So you have to screen for that. You can look for atypical Parkinsonian sign like the hummingbird sign and the red hot cross bun sign, and DAT scan may be considered. In our centers we don't do routine DAT scans, we still do clinical diagnosis. Intraoperatively, you have to do mapping on these patients. After selection, you do post-operative programming on these patients with all the protocols, and we are getting close to the last portion here and solving the question for Raza. Here's a picture of my home aquarium, by the way. If somebody has interest in fishes, we can chat. Very good. So Raza went through inpatient on-off DBS evaluation. His levodopa challenge dose was 1.5 tablet of 250 milligrams, so 375 milligram of levodopa. MRI brain images were reviewed and minimal to mild, more than age global cerebral atrophy was noted, but no atypical specific signs. Movement disorder panel 1 labs were reviewed and normal. We did not had DRS screening, but we did both MoCA and MMSE. On MoCA, he's had a delayed recall of 3 out of 5 without any cues. With cues, it was 5 out of 5, and we enlisted all the non-motor symptoms he's having so that we can counsel him what will get better, what will not get better. As you can see, he's already having many non-motor issues. So here's Raza's off evaluation. Let's see if we can play this video. So this is an off state. He has never been on Cinemat for months. So no, it's not, you can think of it as an overnight off. It is being done in the morning. You can see the resting tremor, you can see the bradykinesia, akinesia. I'm going to walk through a whole unified Parkinson's disease rating scale with him and collect his score. So you can see the tremors and everything. I'm going to just jump in. So now he has received 375 milligram of levodopa, and he is in a full on state, the best on state we can get on him with levodopa. The tremors have improved, and we're going to look at many features.
Keep your eyes closed. Tell me the days of the week backwards.
Sunday, Saturday, Friday, Thursday, Wednesday, Tuesday.
So he still has some foot dragging on the right side, he still has some jerky tremor which may be dystonic, doesn't look like a typical resting tremor, and we're doing his gait, time gait and all of those testing to see how will he do. So here are the results of all the testing. When in the baseline during the clinic visit, his UPDRS score was 56, and then other components of UPDRS total score of 81. And then on the off state, we found in the morning 63 score, total 88. His time get up and go even in the off state was 9 seconds, and his Berg balance scale was 38, having significant balance problem in the off state. In the on state, his score dropped down to 23, so more than 60% improvement. Total score was 48. So, and then time get up and go was already good at 9, but went down to 8, and Berg balance score significantly improved to 53. So he had a significant improvement in his balance components, even though he's not having any falls, and he's not complaining of any postural instability, and his pull test was 0 on the UPDRS. So you have all this information now, and then we come to the same question. should get DBS surgery. What would you tell him about benefits and what target would you select for the lead? Okay, well, we'll come back to this again. So what target is better for DBS? What are the targets of DBS? In 1950s, we started doing these thalamotomies, and then soon after, Lexell came with the pallidotomy, posterolateral pallidotomy, and we were doing them for tremor, either Parkinsonian tremor or essential tremor. Then we started having deep brain stimulation, initially tried in thalamic stimulation for tremor only, but soon we realized that thalamic stimulation helps tremor and it doesn't help anything else. So for Parkinson, we need something different. And then pallidal stimulation and STN stimulations were immediately revived. Pallidal stimulation came from that historical background of pallidotomies from Lexell, and then the STN stimulation came from, so this is the pallidotomy that the Lexell was doing posterolateral. The Mellon DeLong did a lot of work on monkey models of Parkinson's disease using MPTP. MPTP was discovered accidentally because of poisoning in California, but then immediately many investigators started using it to create a lesion in one side of the brain of monkey and look at it. And Mellon DeLong, during his work, proposed the proper direct-indirect pathway hypothesis in 80s or late 70s, I should say, on the direct pathway and indirect pathway, and explained how basal ganglia works. That is not true anymore, but that was the old concept. And then he was the first one who said that the STN is extremely active in monkeys with Parkinson's disease. So it probably is very active in humans with Parkinson's disease. And because this paper was very, very powerful when it came out, the person who started the DBS process in Parkinson's, Dr. Benabed, immediately jumped on his information of STN being very active, and Mellon DeLong proposed that STN lesions in humans will improve Parkinson. It has not been done before because lesional surgery was not used in STN, it's so deep. So Dr. Benabed had patient with thalamotomies on one side and he wanted to do DBS on the other side, and he said, let's try STN. You could just try things back then. So he put in the DBS wires in STN and it worked very well. It worked so well that most people then forgot about pallidal stimulation and they started doing subthalamic stimulation. But all the 50 years before the STN stimulation was pallidotomies and pallidal lesions in Parkinson. And now there's a revival of pallidal stimulation coming back, and we're realizing all the problems with STN. So now we have three targets. We always had thalamic target for tremors, but we found out it does not work for Parkinson. We have our target of GPI, globus pallidus interna, with pallidotomies that have been done in the past, and then we have the subthalamic nuclei as a target. Other targets have been looked at and mostly failed, so we will not review them. We'll focus on these three targets: the thalamic target, the globus pallidus interna, and subthalamic nucleus. And we'll do a very short, quick comparison that how are they different and how are they similar. Remember, principle number 3, motor symptom control is the same for both GPI and STN. There is no difference in motor symptom. But then let's look at what is different. So here's VIM. So inset over there, you can see the cross section. So we are doing a thalamic stimulation and there are multiple nuclei of thalamus, and we're going for VIM. And then we have GPI, globus pallidus interna. So you have the bigger nucleus outside is the externa, the putamen, then externa, and then interna. The small one in the deep one, the most medial one. And then we have the subthalamic nucleus, which is very close to the red nucleus. So one thing that we have to watch for, and then medial lemniscal pathways also run between the red nucleus and subthalamic nucleus. So these are the three targets that we have. How are they different, and what's better in what? So red will tell you who's the weakest for this one. So motor control, VIM, no changes in Parkinsonism except tremor control. It can control Parkinsonian tremor. It can control Parkinsonian tremor. However, it will not control anything else. STN and GPI, both are equally effective. They will improve the on time without dyskinesia. They will improve the UPDS part 3. So here's some data. Here's the old study, thalamotomy versus pallidotomy. You can see that writing and gait was getting better with pallidotomy, thalamotomy making no difference on that. So we already knew that. Here's a comparison between STN and GPI, and you can look at on without dyskinesia, which is the red portion here. is getting better in both of them, and there is no statistically significant difference between the two. And UPDRS 3 score improvement, again very comparable between STN and GPI. They both improve the motor rating scale, so they are good for motor targets and equally good for motor targets. Cognition. So what about cognitive changes? VIM, there is no concern of cognitive change. So if you really have a patient with mild or moderate dementia and the tremors are so bad, even if it's Parkinsonian tremor, that they are not getting better with medication and you need to do something, you can do a VIM DBS because you know for sure that the cognition will be fine. So you can do a VIM DBS and tell him we'll make your tremors better, it will not improve anything else. And we do that option a few times a year. Between STN and GPI, so far the study suggests that STN has a higher risk of worsening cognition as compared to GPI. These were subset analysis, so it may not be 100% accurate. So in other studies, when the subset analysis, when look at some of these questions, we found that patients with STN were having worsening of cognitive performance, especially verbal fluency and processing speed. Both of these things are not well tested on MMSE and MoCA. That's why you need a dementia rating scale. So somebody who already has problem with verbal fluency or already have problem with processing speed will get worse with STN. GPI so far seems to be a little better. So if you're having this mild MCI patient and you want to do a surgery on him, then you may be better in doing a GPI than STN for cognition purposes. So here's the comparison in that study by Follett between STN and GPI. And if you look at the verbal frequency and processing speed, and they had a baseline score of around 90 for both group, and there was a drop in STN to 84 and relatively less drop in GPI to 88, and this difference was statistically significant. Mood and depression, again VIM very safe. If you have a neuropsychiatric patient and you need to control tremor, you can do VIM, but STN can worsen depression, and there is at least one suicide in patient who had STN DBS in the trial, while GPI seems to be safe. Again, these are small numbers. In 255 patients, there was just 4 deaths and 1 due to suicide, and that's such a small number that you cannot be very sure that GPI is safer than STN. But based on what we know so far, it seems like STN is a little more likely to cause post-op depression, post-op apathy, and even increasing risk of suicide compared to GPI. So if that is a concern, you may have to think again. Typically in our center, we will not go for DBS if there is a clear untreated depression, and we will treat it aggressively first for 6 months to a year, control it to be a controlled depression before we'll go for DBS for any target, and we'll probably lean towards GPI. We do about 20% GPI and 80% STN in our center. So here's again a change in the Beck depression inventory for GPI. It didn't change much in STN and came down a little, while in STN it went up after post-op. The depression was worse. Medications and dyskinesias. VIM has no effect on dyskinesias, positive or negative, and VIM has no effect on medication. But STN and GPI are extremely different here, extremely different, poles opposite. STN directly causes dyskinesia. Even if the patient is not using any medication, just by turning up the stimulation on STN, you can cause dyskinesias, while GPI directly inhibits dyskinesias. So if patient has medication-induced dyskinesia, you can turn on the stimulation on GPI and stop the dyskinesia. So based on that, what happens is that in the trial, when the patient gets STN, he ends up going down on the medication because he has such intolerable dyskinesia. So you're having motor benefit from STN, at the same time you have to lower your medication so that the dyskinesias are not a problem. While in GPI, the patient remains on the same amount of medication, because even if he had dyskinesia before the surgery on the same amount, you can use the same amount and block the dyskinesia with the stimulation. So you can keep him on the exact same dose. How is that important? Well, it's important in two purposes. You have one patient who says, I will not take medication. I want to be completely medication off, or medication caused me to have severe anxiety attacks, or I have medication-induced dystonia. Then you can do STN and get him completely off of medication. Many centers can do that. While if you have a patient who's having problems that only Sinemet responsive, so he has improvement in his mood with the Sinemet, he has improvement in his gait with Sinemet that you may not get from DBS, and he has many other non-motor problems, better sleep, less fatigue from Sinemet that will not get better with DBS. You want to keep the same amount of medication. You go for GPI. so that you can keep the same amount of medication and you don't have to worry about it. So that's a very important difference. So changes in the dose in the first trial by Follett, you can see that the medication were around 13 to 1400 milligram of levodopa at baseline. It came down a little to 900 milligram, but in STN it came down quite a bit to less than 900, so more than actually 1100 on the GPI group. And in the later studies, it's even more. We have found that you can actually get 20% of patients off of medication completely if you do STN, and majority of patients can get down to less than 50% of their baseline medication after doing STN. Gait, VIM, no definite effect, but may increase falls, that's still debated. Will worsen gait, and falls may or may not improve freezing, while GPI has no negative effect on gait. This is a debated topic, but in our centers, if we are unsure of the gait issues, we'll lean towards GPI, because STN definitely does not help gait and may actually worsen it, while GPI may or may not help gait. That question is being debated, but at least does not worsen the gait. So if gait is a problem, we go for GPI. Medication, as I said, more than 50% reduction. Surgical mapping, so it's more practical issues. Doing the surgery is very easy for VIM in our centers, and STN is relatively easier. Intraoperative neurophysiology is easy, intraoperative stimulation is easy, while GPI, very tough target. Intraoperative mapping is harder, and intraoperative stimulation is much, much harder, and the speakers after me will explain that to you better. Programming, very, very different programming. VIM, easiest programming. In few hours you can learn the programming of VIM, while STN is relatively easy, it's much harder, but the importance, it's still relatively easy. There's not too many complex algorithm, but it needs frequent visit. You can't just do programming in one day with STN. You have to do it multiple times over weeks and months of doing the programming. GPI, you can do the programming in 2 days straight. You do 8 hours one day, 8 hours next day, and in 14 to 16 hours, you're done with your programming. However, it's a very complicated programming with a lot of algorithm on what to do next, and switching between back and forth. So it's a harder programming, but as you can just do it in 2 days and forget about it. STN, you have to do it multiple times. So coming back down to the basic, what's the goal? Why debate all of this? The goal is to provide good quality of life to your patient for as long as possible. And DBS can take you much further along after medications are done with. So remember that, educate your patients right, set realistic expectations, and they will be delighted by this therapy. Thank you so much. Here's my team again for movement disorders.
If you have any questions from Dr. Danish or any speaker, you can ask.
Dr. Danish, I'm Dr. Sonawala. Thanks for a very comprehensive talk. My question was on the role and on the benefits of the newer modes of Cinemed therapy versus DBS. Now we can give Cinemed by a PEG tube continuously, and I think last time, was it you or was it Dr. Javed who showed us a couple of patients on continuous Cinemed therapy doing extremely well. My question is, how does this therapy of continuous Cinemed compare with DBS?
So very good question. As far as the continuous Cinemed therapy goes, most of the pills, including the new one, Rytary, that came out that Dr. Shirani was reviewing, is not a huge difference. It adds maybe 1.5 to 2 hours a day, so it doesn't change the motor fluctuations a lot. We have maybe about 50 patients on it, but we're not a big fan. The real continuous levodopa therapy is the Cinemed pump, the Duopa gel. So you can put the pump and it gives the medication continuously. In terms of improving the on time without dyskinesia, it's very comparable. It's 6.1 hours for the DBS and it's 4.7 to 5 hours for levodopa. So you can have similar improvement in the total on time, reduce the fluctuation, reduce the dyskinesia. However, the challenge is that it's still levodopa. So if your patient is having hallucinations, if your patient is having levodopa-induced dystonia, levodopa-induced anxiety, that will still be there and may even get worse, because in all the trials on continuous levodopa infusion, they were using more levodopa. So if the patient were on baseline 1100 milligram of levodopa before going into that trial, they end up going up to 1400, 1500 because they were able to tolerate more of it and they needed more. So that's why they were getting motor benefit by going up on the dose, but that will give you psychiatric side effects, depression and all those issues. So The other downside with the levodopa infusion pump is that so far levodopa has to go into your stomach. So whichever way you use, you either put an NG tube in, or you put a PEG tube in, or you do some tube, and then you do the continuous infusion either in a bag or with a pump. Now that's cumbersome. You have to prepare that every day, you have to walk around with it every day, while DBS is something you place in the chest and you forget about it. For 3 years or so, as long as the battery is running, the patient has to do nothing every day. He has no preparation, no cleaning, no preparing, no forgetting or anything there. So it's far more convenient than a daily levodopa, and the cost so far is actually more for continuous levodopa. In our center, we use continuous levodopa for patients who are DBS failures. So we were evaluated them for DBS and they were not a candidate for DBS for surgical risk or depression or cognitive impairment or other issues, and we have to do something for them. Then we go for a continuous levodopa infusion therapy. We have about 12 patients now on the Duopa pump.